Thank you very much, David, and thank you, everyone, and thank you for the opportunity to talk today. Hopefully you can see my slides. My name is Dr. Michael Abouyannis. I'm a Wellcome funded academic clinical fellow. And as you just heard, I work at LSTM, and I'm also based at Khalifi, where I work with Khemri Wellcome. And today I'm going to be talking about a project we've been doing over the past year to develop a global core outcome set for snakebite randomized controlled trials. So why is a core outcome set needed for snakebite randomized controlled trials? To confirm the answer to this question, we started by conducting a systematic review to look and see how much heterogeneity there is in outcome measures. And across 58 therapeutic RCTs in snakebite, we identified 153 unique outcome measures. Even looking just within primary outcome measures, of which there were 28, we found that 23 of these were unique to a single study. And then even looking at specific types of tests, so for example, bedside clotting tests, there were 18 different methods of measurement. So what is a core outcome set, and how can it help us overcome this heterogeneity? So it is a list of minimal expected outcome measures for randomized controlled trials in a certain disease area. And these are available for many diseases now. It's important to note that these are the minimum expected, but that trialists are free to measure any other outcomes that they wish, and that the primary outcome of a trial does not need to be a core outcome necessarily. They're normally developed by expert consensus, and this process and guidance is available from the COMET initiative. So in terms of who was involved in developing this core outcome set, there was the stakeholder group, which was a multinational group of academics, clinicians, statisticians, and funders, with representation from both low and high income settings, and representation from these organizations, including LSTM, the World Health Organization, MSF, and Khemri Wellcome, and various others. There's also patient involvement, with a patient group being formed in Khalifi in Kenya. And the primary purpose of this is to feed into the patient-centered outcome measures and to make sure that patients feel that we've got these right. And we're also inviting broad expert feedback. In particular, we've approached the authors of previous snakebite randomized controlled trials and ongoing randomized controlled trials. So one challenge with outcomes in snakebite is the diversity of syndromes of envenoming. And this is something that we have dealt with by splitting outcome measures according to the clinical syndrome. So although some outcome measures can be universal, such as mortality, disability, and antivenom allergic reactions, in that they should be measured in all snakebite clinical trials, some should only be measured when the relevant species causes that syndrome. So neurotoxicity, hemotoxicity, coagulopathy, local tissue damage, nephrotoxicity, and hypotension. And it's at the trialist's discretion as to which of these outcome measures to choose, depending on their population and the biting species in the population. And so this slide aims to give a summary of how we whittled down the outcome measures. So we started off with over 100 from the systematic review. We then categorized these, as mentioned, into the syndromes of envenoming. We then developed a literature pack providing background literature in an unbiased way, and shared this with stakeholders and expert groups along with the questionnaire. And the questionnaire essentially listed all of these outcome measures and asked for them to be scored based on certain criteria. This then enabled us to rank the outcome measures and to shortlist the highest scoring ones for discussion in the consensus meetings with the stakeholder group. So there were 4 meetings, each meeting lasted a few hours, and once consensus was reached, we held a vote to confirm that there was 70% or greater agreement on the core outcome measure. And at this stage, we are seeking expert feedback and also patient group feedback before we finalise and disseminate the core outcome set. So I haven't got time to go through the whole core outcome set in this talk today, but I will just touch on a few of the categories to give an idea of which outcome measures we came up with. So this is the category of disability, and there were two core outcomes within this category. The WHO Disability Assessment Scale. Now, this is a generic measure of disability. It's measured using a questionnaire, and it's been validated in low income settings. It's designed to be cross-cultural, and it's available in various languages. The other core outcome measure was the patient-specific functional scale, which some of you may be familiar with as it's been used in snakebite trials in the past, although only in the USA. And this tool is highly patient-centered because patients are asked to choose functions that are important to them. For example, someone may say that they want to be able to return to work, and then over time they'll grade to what degree they've had recovery of that function. These tools do need further validation in LMIC-based snakebite trials, but no tool has been used in this setting in this way to measure disability. And given the target to reduce disability due to snake bites, the group felt it was really very important to include a standardized measure of disability. So the final universal outcome measure I'll mention today is of allergic reactions. So we wanted both a measure of anaphylaxis, and the group selected the Brown grading system. This gives a ranked grading of clearly defined allergic reactions ranked as mild, moderate or severe. And we also felt it was important to include a definition of serum sickness. And there's not that many definitions available for serum sickness, but one that was published by the Australian Snakebite Project group was identified. And as you can see in the bottom right table here, if an individual has 3 or more of these clinical features with an onset at days 5 to 20 after antivenom, then they fulfill the criteria for serum sickness. So on to the syndrome-specific outcome measures. I'm just going to talk about 2 examples. The first is the neurotoxic outcomes. So although intubation and ventilation have been measured in previous randomized controlled trials, standardized definitions often haven't been used. And so we wanted to try and identify some sort of established way of defining these events. And thankfully, a core outcome set is available from a critical care group who developed this core outcome set for ventilation trials. And so we've adapted this. And this is the core outcome measure. So there's 2. The first is proportion needing intubation or ventilation within 48 hours of randomization. And the second is the mean and median duration of ventilation from randomization until first successful unassisted breathing. And these terms are defined. So unassisted breathing is defined as not requiring any inspiratory support except for high flow or CPAP. So only bi-level pressure ventilation would meet the criteria for assisted breathing. And success is defined as stopping assisted breathing and staying off it for 48 hours, essentially. So often when people are weaned off a ventilator, they may then relapse and need to go back onto the ventilator, and it can get quite difficult to define the duration of ventilation unless a clear definition such as this is used. Now, this was selected as the neurotoxic outcome measure because the group felt that the aim of treatments should be to prevent respiratory failure and to prevent death, and therefore measuring it directly in this way was felt to be highly important. A drawback of this is that there is varying access to critical care, particularly between low and high income settings, and that can make comparisons difficult. But that is often the case when making comparisons of a trial based in a low and a high income setting, unfortunately. So the coagulopathy outcome measure, the group decided that the mean and median INR measured at 6 and 12 hours after randomization should be included as a core outcome measure. This figure here is just to give an idea of how the INR can recover over time. So this is an example of Russell's viper envenoming. And of course, this will vary somewhat between species. But you can see there is a gradual recovery of the INR with antivenom treatment. Now, the points considered by the stakeholder group in selecting this core outcome was that a standardized validated assay was needed, and that although bedside clotting tests do offer certain advantages, their use as a tool of to measure success of treatment currently doesn't have enough validity data to use as a core outcome measure. Another advantage of the INR is that it's a continuous measure, and this can hugely increase the sensitivity of the outcome measure to detect a treatment difference. So you can detect quite small differences. And given that snakebite trials often have a small sample size, having sensitive outcome measures is quite important. Now, of course, the challenge with lab-based INR is that this is challenging to implement in low-income settings, particularly the sub-Saharan African region. But I think it's important to note that this is only for use in trials, which will obviously have an associated funding package, and it's only as an outcome measure. So this isn't proposed as a tool to use when someone presents to make a decision about whether or not to give antivenom, where often a bedside clotting test would be more appropriate. It's purely as a test of success of treatment. And samples can even be frozen and stored and analysed in batch at the end. So another important thing that the group considered was how to align follow-up time points so that the challenges of measuring additional outcome measures wasn't too great for trialists. And so the majority of the core outcome measures are within this orange box, which all occur within 48 hours of randomization. And therefore, all of these things are very likely to be measured whilst the participant is still in the hospital environment. There are two time points for outpatient follow-up at 2 weeks and 6 weeks, where disability is measured, mortality, and serum sickness. And of course, a lot of these events are things that occur during that follow-up time period. But the vast majority of these can be followed up by telephone. So face-to-face follow-up is not necessarily required for these core outcome measures. So to conclude,
Michael, you've got 3 minutes to go.
Fantastic, thank you. Thank you. So yeah, to conclude, the standardization of outcome measures is important because it supports future meta-analyses where like-for-like outcomes can be combined, and small studies can be combined to identify pooled effects. It also allows comparisons between different antivenom products. So it might be if two efficacious antivenoms were identified, it might be helpful to compare the rates of anaphylactic reactions, and that may be a reason to choose one antivenom over another. And so it's important to use the same definition of anaphylaxis in order to make such comparisons. And thirdly, I think another hopefully important output of this work is that more clinically significant, but also more patient-centered outcome measures may be used in clinical trials going forward. Now, one of the challenges has been the limited data on outcome measures in snakebite trials, and in particular, the lack of validity data for surrogate endpoints. So this core outcome set is by no means perfect at this stage, and it's very much a foundation of work and a starting point to build upon. The tool will be reviewed in 5 years or earlier if new data is to emerge. And as I mentioned, feedback is welcome. If you want to view the full core outcome set, then please write down this link, and this will take you to an online form which gives a bit more background on our project. It lists the full core outcome set, and there's also a free text box available where we would very much invite and appreciate feedback from yourselves. So I'll just finish by acknowledging everyone who's supported this project. So the stakeholder group who have given up an enormous amount of time and also worked really hard to carefully consider these core outcomes and to debate them and work together and to come to agreement on them. And also to the other experts who have given up their free time and been extremely helpful in providing their insights to these outcome measures, and to everyone's respective organisations for supporting us in this work. So I'll finish there, and thanks again for the opportunity to talk, and I'll be happy to take any questions.